So we've been talking about articular cartilage, and as we've already seen, once you develop a defect in the articular cartilage, like we see in this young rugby player, if you wait over time, you could. One of the ways the body reacts to this is developing hypertrophic bone in the area of the articular cartilage, which we call subchondral osteophytes. And this is just another example where over a year and a half you can see going from the normal subchondral bone with a little bit of irregularity here to this hypertrophic bone formation, which we call subchondral osteophytes. And usually overlying that, there's no cartilage when these develop, but you can get a little fibrocartilage sometimes develop overlying these subchondral osteophytes. And here we can see in the coronal plane, the cartilage loss here after the injury and the subchondral bone formation there. Notice also, if we look here, we can see that these marginal osteophytes over this time period have also grown over here in the margins here and also over here. So that's the body's attempt to try to heal the injuries. Okay. So Jennifer, here's just a question. How can we determine whether the cartilage is intact over these or not?
All right, so here on the proton density sequence, we don't see the cartilage as well. It looks like there may be some irregularity of the subchondral bone plate, but then on T2 we can see fluid signal intensity extending all the way to the subchondral bone plate. So this is a grade 4 chondral defect, and then here we see on the thinner slice cube images that there's definite grade 4 chondral loss with subchondral osteophyte.
Sometimes on these thicker cuts to determine that. The thinner cuts really allow us to see the morphology a lot better, and so this was full thickness defect. So that gets us so if we make the diagnosis of these things, what can you do about it? And
John?
Yes, John.
Can you go back on the last one? Is that on the tibia? Is there a kissing lesion?
Yes, there is. And on the thinner cuts, we can see that the fluid goes all the way down to the subchondral bone. So this is a great point.
Yeah, I think that's an important thing to mention in a report.
Good. Yep. I agree. So there are a lot of treatment things. We'll talk about subchondroplasty, arthroscopic debridement, pinning, microfracture grafts, and chondrocyte transplantation techniques. So here's a patient with chronic knee pain. What do you think, Michael?
Okay, so in the medial compartment, there's extensive full-thickness cartilage loss or grade 4 chondral malacia with subchondral marrow edema, debridement, small osteophytes. And then we just see kind of more of that on the sagittal images. And there's some increased signal within the meniscus as well. There might be a degenerative tear.
Okay, so this is 5/18/18. So the patient had a procedure 4 months later.
So 4 months later, and they had a procedure done?
Yeah.
Well, the tibial plateau looks like something was done to it, almost surgical, like there's now a defect through it.
There it was before.
Yeah.
There it is now.
So unless that's, I mean, that's either some weird surgical like osteotomy type thing, or there's a tibial plateau fracture. Like a subchondral fracture almost.
Yeah, so this is a subchondral, which is where you basically take that part of the knee kind of off weight bearing by basically doing an osteotomy underneath it, right? I've seen very few of these, but that's one technique. John, do you have a comment?
I've done a few, and that's because you have usually tibia vera, and or you can say genuvarum, and so you do an osteotomy to put it in more of a valgus position, and take the pressure out the medial side, which is usually the problem in men. In ladies, it's the lateral side, but you never want to do a procedure to change from medial to lateral in women, or from lateral to medial, I should say. You get into trouble. I had one case that I did, and I regretted it ever since. But the patient became one of my best friends,
Okay.
or my wife's. Anyway,
All right. Thank you. All right, Ashley, what do you think of this case?
So we're looking at the lateral compartment. We see full thickness chondral loss, lateral femoral condyle and tibial plateau. There's some subchondral, there's some marginalized osteophytes, I thought, there as well. On the sagittal image, we see it's more of the posterior aspect of the articulating lateral femoral condyle and lateral tibial plateau, full thickness chondral loss there, and some eburnation.
Okay. So this is a case where they did a debridement, which is no longer recommended, but they did a partial meniscectomy, and there was a lot of irregular degenerative type articular cartilage that they didn't removed. And that's something that was kind of commonly done in the past, but a couple of studies came out a few years ago showing that the patients did not improve with that. So debridement is no longer recommended.
it wasn't recommended here in Southern California. I know that. I never saw a case. I never did one.
Good.
That one thing about doing an MR on somebody like this, if you look at the coronal image on the right here and on the left, it's hard to tell in a patient where there's no weight bearing whether there's any help for the patient in terms of changing the position of and in terms of pressure, whether the joint closes or not. On X-ray in a standing position, you get a better idea of that. In other words, you probably don't see a joint at all if this patient stood up on the lateral side.
Right. Good. Yes.
So you think that you may think that this is a good result because you have a nice opening there, but that's fooling yourself.
Good. Okay. So another technique is if you have an acute fragment, you can pin it back in place and hope then that it heals to the subchondral bone. This is a successful one. Here are the little pins that were put in place. This patient had an overlying cartilage defect, and now you can see the cartilage looks nice and smooth in that area where the patient was.
And as a kid, and that I've done my share of these, and they work out pretty well.
Good. And here's just another example where there's pinning. Now, let's see. Jennifer, what do you think of this one?
So we can see also that the physes are open, so this is probably an adolescent or patient, or at least pediatric patient, and there is a full thickness or grade 4 chondral defect there.
So what do you have to do?
And so you have to look the rest of the MRI and try to find that displaced chondral fragment to see if it can be repaired.
Look on the left image and see if you see something interesting there.
Oh, I see it there along the posterior aspect of the lateral tibial plateau. There's that displaced chondral fragment.
That just might be it.
So,
What do you think, John?
yep, that was it. Here's a follow-up.
You may try to pin that back, and
Here we can see on the post-operative MRI that they have some pins and they've reattached that osteochondral fragment, and it looks like it's healing well.
yes, it does.
John, Michael has a question for you.
Like, so what are these pins? Like, what type of material are they?
John?
Is somebody asking me a question?
Yeah, I was wondering what type of material these pins were. Like these contacts.
I'm sorry, but I cannot hear you properly.
It may be his mask. He wants to know what kind of material are the pins made out of?
These pins, I'm not. It looks to me like steel, but I can't be sure. They're not bright at all. There's no brightness, so it must be something, some other material that I have never used.
Yeah, no, I'm not sure.
I can't, and I cannot tell you.
Okay. This gets us to probably the most commonly performed procedure, or one of the most common anyway, which is called the microfracture or marrow stimulation technique. And this is a case where you see the area of articular cartilage deficit. You remove the cartilage back to where you get close to normal cartilage. And then you do a microfracture technique where you bring clot up to fill this particular area. We saw a little example later, and I think I'll show that same one in a minute in this area. And this is supposed to bring marrow stem cells into this particular area, which can then differentiate to form fibrocartilage. So this is the example we saw before. Here is the area when you first go in with the tourniquet up, so there's no bleeding, and we can see that fraying of the cartilage, full thickness grade 4 defect going down to the subchondral bone. There we can see it with a little bit of debridement. Here's when you take off the tourniquet, so you see bleeding into that particular area. And here it is before closure. And as we saw before, if we look, here's early on where this is fluid going down to the bone. And here a few years later, I think when the patient came back, you can see what looks like some fibrocartilage overlying that gap. And this is almost 6 years out. So at first people thought that this might be temporary, only a few years, but now there are cases where people have developed fibrocartilage which has stayed and become functional for many years after the microfracture. So this is one of the technique used for full thickness defects. John?
I think that's the most popular procedure that's done. And then there are different reasons to do the different type procedures described. But a lot of people will just do a PICC procedure like this instead of going through the other ones.
Yeah.
This was my favorite procedure to do, and that's about the only procedure I did.
Good. Okay.
I did some drilling using K-wires and deeper
Okay.
lesions, but on not deep lesions, just cartilage absence or a 4th degree type of lesion. I just picked.
Okay. The
I was a cartilage picker.
Okay. So in this particular paper by Gramazzi, there are poor prognostic findings in this technique if the defect was not filled at 2 years, if the surface was poorly defined, persistent hyperintensity, and persistent subchondral edema are the things you look for, which are poor prognosis. Then the next technique that can be used if you have a defect, especially in a younger individual with really pretty good cartilage, is you take osteochondral plugs from a non-weight-bearing area of the joint, and you plug them in after you debride out the area in the weight-bearing portion where you have the chondral defect. And so here we can see a defect in this location, a little bit of underlying bony changes. And here, after the surgery, we can see that there is articular cartilage here, and the bone in this case is healed where they put in the osteochondral plug. So this was an osteochondral plug technique, and this is pretty successful. And what you look for is how smooth the surface of the articular cartilage is. And also, you look to make sure that the subchondral bone matches in the same plane.
One thing, it's a very, very difficult area to get to if you're looking at this particular region.
Yeah. So here's another example where we see the defect here, and then they put in the plug. We can see the plug's a little bit proud, but not too bad. The overlying articular cartilage is definitely thinned in this location, and we can see now 3 years later that there is fluid really pooling right around the bone in this location. And at follow-up, the bone healed pretty nicely here, but there was abnormal cartilage in this location at follow-up arthroscopy. And here we can see on the fluid-sensitive images in the coronal plane. And so you kind of look for graft incorporation. This, unfortunately, is more like what I've seen over the years. Here we can see there's a big osteochondral plant here. Notice the subchondral bones do not line up very well. This one is very proud in this location. So this was shortly after the surgery, just a little bit after the surgery, 9204. And we can see just 2 months later that bone is ground down, and there is no cartilage overlying this. The patient has a bigger effusion here. So this patient did not do well.
Would this be an indication for revision if you see like over 1 millimeter subchondral plate difference on the plug?
Yes, there is, but it depends on the age of the individual. If an individual is over 45 or thereabouts, you may do a compartment replacement.
Yeah, there are a couple. Go ahead, John.
They're become quite popular.
There are a couple of things to notice here. Notice that the radius of curvature of the graft is not the same as the radius of curvature of the underlying bone in this location. This is much more curved. The graft is much flatter. So the morphology of the graft doesn't really fit with what you're trying to replace here. And you really don't want it to be proud like this. These proud lesions will fail virtually every time, which is what happened here.
Was this proud from the get-go, John, or because this looks like it's healed?
Yeah, I think, well, this is the first MR that was done after the procedure, and it showed that it's very proud.
Okay.
Now, here's another example. Here was before the procedures. Here they put in 2 plugs. But again, notice that the subchondral alignment is not very good on both of these plugs. And we can see a lot of bone marrow edema underneath here. And this patient did not do well and went on to increasing pain. So a big problem with these plugs is getting them to align. They need to almost near perfect alignment. being proud like this is a very poor prognostic factor, and all this edema within the bone lets you know that it's not healing properly. Okay, let's see, who's next? Who's last? Okay.
Anterior knee pain.
Anybody guess why the pain is anterior?
I think that's where the issue is. So there's kind of subchondral irregular defect in the lateral trochlea. The adjacent patella looks okay. Actually, there's a little bit of, I guess, sclerosis. Mm-hmm. So, I mean, so there's chondral thinning with kind of subchondral collapse and probably insufficiency fracture, deficiency of that lateral trochlea.
So, this is on 11/15/07.
Mm-hmm.
The patient then had surgery.
Oh, okay.
And had an osteochondral graft in the trochlea here, and this is a follow-up MR exam.
Oh, so this is a graft.
And so this is the actual graft, and you can see a little.
Okay, I see that. And then, I mean, it looks like the cartilage is still intact over the lateral trochlea. It's just a little thinned, but it looks like there is cartilage.
So this is osteochondral, and this patient was actually doing well at this particular time. Had some knee symptoms, but they were not the same as before, and they were due to other pathology in the knee. So this is a relatively successful graft. Now, if you look at outcomes of grafts in this American Journal of Sports Medicine paper, mean survival rates at 5 years was actually pretty good, up around 87%, and then it dropped down over subsequent years. So I guess in radiology, we tend to see the failures because they're the ones that come back with symptoms. So I would have guessed that the rates were much lower than this, but that's probably because we have selection bias where we just see the people who don't do well, mostly. Okay, Ashley, what do you think of this case?
So we see that there is a focal defect of the is that the medial femoral condyle there is a grade 4 chondromalacia. It's posteriorly there.
Okay, so this is on 8/30/04. This is on 8/29/05, a year later.
Well, I think they put in an osteochondral graft here from the lateral tibial plateau, lateral femoral condyle to the non-weight bearing portion of the lateral femoral condyle, and they put it in that previous defect area because you can see a small defect at the donor site and the graft site. So
that's known as an autograft.
Yeah. So this is one of the forms of autograft. This is called paste graft. The only person I know who does these is Dr. Stone up in San Francisco. What you do is you basically take an osteochondral plug, and he takes them from the notch here, which is non-weight bearing, basically grinds it up and just pastes it in where the defect is in the bone. And much to my surprise, these do actually very well. In fact, that's another study that we could do. We've got a large number of these patients with follow-up where we could actually get some numbers. But so this is what he calls a paste graft, and we've got a number of examples now where they've done pretty well. Here.
Did they use the sandwich graft, the name for
I don't know what that is.
I read in the latest Campbell's that it's a double layer and you kind of complicated procedure.
Okay, interesting. Maybe they have one with pieces of bone and calcium deep, and then just cartilage on the top. I don't know. I've not heard of that one. Here's another paste graft. This was in 9/19/01, shortly after it was put in here. And here's a follow-up a few years later, where we can see that there is cartilage here. Now, one of the complications you can get from these kind of techniques. This, and then when we talk about chondrocyte transplantation in a minute, we'll come into it also. Notice that in the area where we put in the paste graft, it's quite a bit more thickened than it is in the native areas. So this hypertrophic growth of the cartilage is a problem, and occasionally it'll cause mechanical symptoms, and you'll have to go in and scrape this down. So one of the problems can be that you have too much cartilage growth, which can lead to mechanical problems. So this is a paste graft. This patient was actually doing pretty well. Okay.
So here we can see a grade 4 chondral defect along the central femoral trochlea. And here again, there's a grade 4 chondral defect along the femoral trochlea, and there is some mild patella alta.
This is 4412. Patient came back from 7718.
Okay, so it looks like there's been some type of graft. There's a subchondral bone plate, and there's been some type of surgery to fill in that chondral defect. It looks intact.
So this is another paste graft using this same technique. So much to my surprise, I've seen some of these really have rather marked improvement, and this is something we really should publish, and we can have the data on it. And here's another case of a paste graft. So next, we can go to the chondrocyte transplantation techniques, or what's called cell-based repair. And there are a number of techniques, and they've changed over time. One of the first techniques, you had to do 2 surgeries. One surgery, you went in and debrided the area and took pieces of cartilage. You took that cartilage and you grew the chondrocytes in vitro. And then you went back with a second technique, and either you took some periosteum and tacked it down overlying the defect in the cartilage and injected free cells underneath it, or you could then put these cartilage cells in a scaffold externally of the right thickness for articular cartilage. Then you go back and cut that into the shape, and then you put the scaffold in the area of the defect. And
this looks like the sandwich graft, John.
Oh, okay. I've not heard of that.
They might have just changed the name.
Good. Okay. This particular one goes by MACI, which is a trade name, and so these are techniques.
Do you know where they strip the periosteum from?
I think it's usually from the. To be honest with you, I don't exactly know, but I believe a lot of them are from the periosteum, from the metaphysis of the tibia. Okay, and here's a patient with an older technique with chondrocyte transplantation, where we have a little bit of metal artifact in the area where the surgery was, but in the area of the transplantation, the cartilage looks very good. On the opposite side, we have grade 4 chondromalacia on the other side. And here, it's a somewhat irregular. The more recent techniques, I haven't seen the metal artifact. Be a little concerned about a little bit of edema on the underlying bone here, and I'd really like to see the surface much more smooth and regular than this. So this I would not call a completely successful technique. Okay, here's a 27-year-old male who had autologous chondrocyte implantation on 4/16, and here you can see a lot of subchondral marrow edema here, which is a little bit worrisome. And here we can see this is the area of the chondrocyte transplantation, and it's a bit proud. It's actually thicker than it should be. This patient did have mechanical symptoms, and they went in and shaved down some of the cartilage to make it closer to the same thickness of the native cartilage. And here on the sagittal image, you can see how much hypertrophy developed in the area of the chondrocyte transplantation. Okay, what do you think here?
Okay, so post-op follow-up. So I mean, I see the chondral defect in the femoral condyle and the medial femoral condyle with some underlying bone marrow edema. This is post-op. So on the PD facet, it looks like there's kind of some irregularity and some fissuring. And this is like a T. Is that a T2 non-facet? Where it looks like there's T2. Yeah. On the T2 non-facet, it looks like there's, you know, there's a normal contour, like there's something. It doesn't have normal signal intensity, but it looks like there's, you know, filling. Like there's no full thickness defect.
So this is another transplant where called a de novo cartilage implant here. Okay, and then here's a pre-op large defect which we see here. This patient had a MACI procedure. This is from the surgery. This is preparing the site for the graft, and then this is 5 months after surgery. Here we can see a little bit of hypertrophic bone, subchondral bone. The cartilage is really thinned here, which you really don't like to see. But we can see that it does look like there probably is filling in of cartilage overlying the defect, but it's much thinner than the native articular cartilage in this patient. Maybe over time it will thicken a little bit, but here's the area of the transplant implantation. And then here's the arthroscopic view of this. So they saw no full thickness defect, but the cartilage is kind of thinned and irregular over that area, and so it's intact. So basically, the last couple of days we've talked about the structure of articular cartilage, some of the pathophysiology of how cartilage breaks down, a little bit about biochemical imaging, which hopefully will, in the future, we'll be able to get good imaging to tell us where the cartilage is at risk and allow us to then develop techniques to preserve the cartilage. But if we can't preserve it, then you can see anatomic imaging where we see defects, and then some of the treatment protocols. And I think there are a lot of techniques out there that are being tried around the world. Only a few of them are FDA approved in the United States. But I think over the next 10 years, there will be many more procedures that will become approved. And the issue of becoming who pays for them, because they're all very expensive. Any questions? Okay, well, why don't we stop here, and tomorrow we'll go back and talk about the shoulder.
Thanks, Dr. Cruz.